kind of. Everybody's gone the 45 minutes?
No.
Okay. Yeah, that was the most important question.
Your mic's on an
hour. Am I on?
Yes, you are on now.
Oh, hello everybody. My name's Ayaz. I apologize for the slight delay. Yeah, and I apologize if this is a little bit disjointed. I've been off since October 22nd, and I flew back home, and I didn't get back into my apartment till like 1 a.m. this morning. Stupid Arkansas airport. So I've been kind of just on a fried egg kind of brain right now. I'm sure you guys also. This is after this past week, probably with all your presentations. So we'll get through this together, and we'll go from there. Did you already share like the whole CV thing?
That's only for us. So.
Oh, good.
Yeah.
That's good.
So, yeah, no one else saw but me, probably.
I apologize if you had to see that. That was rough. It's been a minute since I've updated that. Going forward, about me. That's me. Sorry. That's all.
That was you.
That was me.
You're a whole different person.
That was. It's been downhill since then. That was me at 5, and it's especially after this haircut yesterday. Thank goodness not a video. It's pretty much rock bottom right now. We'll get through this. H's and T's. What are they? I'm not gonna make anyone answer this. It's pretty much. I'm sure you guys all know this. I've had the pleasure of working with a lot of your colleagues this past 2 weeks, and my goodness, and I knew how good you guys were, but no, I'm not just saying this, but for real, you guys are freaking awesome. So you guys already know what these are. We're both causes of cardiac arrest. I was gonna ask somebody to list the H's, but how about one of you three? Can you guys list the H's off the top of your head? Sorry, I don't know. Kyle and
Hydrogen ions.
yeah, yep, that's it. Yeah. Come on. I just hyped you guys up so much. It has to do with electrolyte. It is hypo and hyper. Yeah. And hydrogen ion, hypovolemia, hypoglycemia. I think that's it. Hypoxia. And yeah, 2 more. Sorry. There you go. We'll get through this together. If they actually remove hypoglycemia, I don't know why. I couldn't look deep into it. But I mean, it takes 1 minute to do in your guys' truck, and it's like just give them the shoot. It still can cause coma. I mean, in your setting, and it's like when someone's altered in a coma and obtunded, it's like it's all kind of mixed into one big smorgasbord. Why not check it? It takes a minute tops to do. Except for me, it took me like 4 tries, and I still couldn't do it. I suck. T's. Anyone? Yeah. 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 You removed that though, but yeah. And there's one that covers 2. Yeah. Yeah. And I think that's it. Yeah. Oh, tamponade too. Cardiac tamponade toxins. Trauma again, they removed. That's why I crossed it off. I mean, trauma kind of encompasses a lot. Oh, trauma can kind of, an umbrella kind of cover tension pneumo. Because tension pneumo causes it, obviously, as well as tamponade, but they're all kind of mixed together. But again, I don't know why they remove it. So again, that's what these are. And as we'll go through this, what I noticed was, I mean, I had to get out of my. I'm a Freeman resident ER PGY1. So I had to get out of my doctor head what we have available in the hospital. And I realized a lot of these things, some of these things are useless to you guys in terms of helping fix, if I'm not mistaken, like a thrombosis. Like, how are you going to fix a heart attack in the field? Stuff like that. Yeah, I mean, that's all you can do. You can't, but like the end all like solution, you'll see. So stuff like that. Hypoxia. Shoot, I was gonna have that fade in, but that sucks. I hate reading off. I mean, you guys can read all this, but it's just like it's not rocket science. It's what it says it is. It's just lack of oxygen below 92%, but it's probably way less than that, 80s, 70s, someone that's just not having any sufficient respirations. And with that, you see like, low heart rate on the monitor, you see an QRS. If they're still still conscious, probably altered, not respirating, not having normal chest rise. You may see cyanosis, not as much, just the bluish discoloration of the skin around the lips and just the digits, maybe not as much. It can be caused by, any sort of obstruction of the airway if they, aspirated something, if they just have something stuck in the back of their throat, like a foreign body, if they're just covering their vocal cords and an air hole. Yeah, I don't know how to talk. we have a lot of holes. Neck veins, you don't see that as much. That's very late. At that point, they're probably dead. Hopefully, you don't get to that point. Decrease your output. You guys aren't really worried about that. You're focused on their chest and their respirations. So that's kind of what those things are. Sorry, these slides are kind of boring, but I'll try to get through it. It's not rocket science. Chest compressions. That's why they just emphasize. Obviously cardiac output, but just chest compressions and ventilation, getting some sort of a bag mask set up on them, just having some sort of oxygen input, even if you before you can hope to get to intubation. Intubation obviously is the end all be all solution, and you guys I've seen two of them during my last 2 weeks. Shout out to Priscilla and then whoever Eli's partner was this past month. Sorry, man. Very, very impressive how quickly and how amazing you guys did that. And I've only done like 6. I've 3 for 6. I've broken somebody's tooth doing it. It's innovations is the and however you guys want to manage with medications. I'm not going to go into that route. And then obviously when you verify in the hospital, spoiled X-ray, you guys just got to do it with auscultation of the stethoscope and making sure bilateral with make chest rise when you're bagging them. And then also, most importantly, end-tidal CO2 DC color change, purple, call it to yellow, purple-yellow, right? If I'm not mistaken. And then end-tidal CO2, is that going down to the normal 35 to 45? If not, you got to bag them more quickly. You don't normally when they're intubated, 6 compressions per minute, but if you need to get that CO2 down, just go faster, like a better word of saying that. So that's hypoxia. Sorry if I'm talking fast or anything, but we'll get through this again. Hypovolemia, sorry, all these words. Similar findings to hypoxia, just flat neck veins, pale, cool skin, ARQRS. Again, that was literally hypotension, identical to the hypoxia. The only thing here is tachycardia due to lack of fluids, heart's trying to compensate. Hypovolemia, low fluids, it can be caused by, you guys know, you've seen this, hemorrhage, someone's bleeding out due to penetrating trauma or any sort of just, wound. Lack of fluids, dehydration, a lot of old folks are in the heat. People are homeless, unfortunately. Just see that when they're out in the sun. Any sort of burn victims, just the fluid that just gets evaporated just because of the open exposure. Third spacing, that's kind of remember medical terminology. It's when the fluid goes from the blood. It's a space in between like the cells and the organs and the vasculature. There's a lot of open interstitial space. That's when that fluid leaves the vasculature, the plumbing, and goes into that area. It hangs out there. Sorry, excuse me. I just drank my Monster. And so it's just a lot of swelling. That fluid it's still in the body, but it's not leaving the body, but it's not in the vasculature. So it's in there, but it's not in the vasculature. So how do you fix that? IV access, 18 gauge, bilateral, and just fluids if you can. A bolus as much as you can, and then control, obviously, well, first of all, control the source of bleeding if they're bleeding while getting the IV, and then transfuse if needed. Do you guys carry blood products on the trucks? No, you don't? Never, ever?
No, not yet. It's something, who knows, in the future.
Again, I'm new to this, and I'm not smart, but like, I don't see why not. It's just, I guess you have to keep it fresh, and then it's iced, and it's expensive, but
Yeah, it's the storage.
Yeah.
Short shelf life, you have to use it in 14 days or trade it out. So
Yeah.
take out of the blood banks and end up throwing it away.
Yeah, and I guess I mean, if you can get them, if you're close enough to the hospital, just get them there instead of versus getting it set up. So I guess in that regard, but yeah, definitely just massive transfusion if you can. I mean, just fluids are out, get fluids back in. That's what hypovolemia is. Pretty simple. Um, Again, these are all things. I should go back and consider why did they? I should have explained this at the beginning. H's and T's. Why do they keep on referring to them in ACLS? Obviously, it's more pertinent when you go down the route. I mean, just taking it aside here, it's more pertinent when you go the PEA route when they don't have any sort of shockable rhythm. Obviously, when you have the shockable rhythm, you want to focus on CPR and ventilate and getting them oxygen, but then getting that rhythm kicked back into gear with epi, lidocaine, amiodarone, what have you. So that's kind of the main focus there. I mean, obviously, you're still trying to assess how to reverse it, but it's still want to get that rhythm back into kicking into gear. PEA is when a lot of these H's and T's come more into practical use and focus during code blue. So I should explain this in the beginning because obviously you can't shock it. What are you going to do? You're just kind of go through the ABCDs of what can I do to fix this, and that's where a lot of this things come into play. So sorry for not explaining that at the beginning in case somebody knew. I didn't never paid attention to it in the beginning before ACLS. So it was a good reminder for myself. So that's kind of a nutshell what H's and T's are. So we already did 2 H's. Next one, potassium, hypokalemia. The name says it all, lack of potassium. This is, you guys can you guys do blood gases on the truck? VBGs?
No, some
Okay. So yeah, and I'm sure in your paramedic training you guys did them.
we learn
Yeah.
ABGs in paramedic school.
Yeah.
But we do not regularly take them.
Oh, okay. Yeah. So the only way to figure this out is like hypoxia you can see on the monitor and the SpO2 and then tidal CO2. Hypovolemia you can probably see through the clinical findings, through the blood pressure. Hypokalemia, how do you see the low potassium? The best way for you guys in the field is if you can get an ABG or VBG set up, if you have the tools. If not, it's kind of hard to figure that out. But that's low potassium below 2.5 primarily. I mean, ideally it's defined as 3.5 normally, but you really see a lot of the severe symptomatic outcomes when it's below 2.5. What can cause it? If someone's on a bunch of diuretics, Lasix, spironolactone, Bumex, you can maybe get that in the code blue when you're talking to family members and whatnot. If someone just kind of took too many of their diuretic pills, maybe that can kind of link that together why they're going to cardiac arrest. They're given fluids that are, if they're on parenteral fluids that are low in potassium, that can also cause it. Any sort of excessive GI fluid losses from suctioning or lavage, also like people who've had like recent gastric surgeries, they just spill a lot of potassium out just because the anatomy is not what it used to be, and so prolonged vomiting and diarrhea. This is probably the most common finding that you would find it in someone in the field. I don't know, for whatever reason they're vomiting due to any sort of nausea, eating something, or just self-inflicted or diarrhea and stuff like that, or laxative abuse. So that's if you find somebody covered in a lot of their stool and not for real, like they're just unconscious, that may be something to jump to. Considering why they're in cardiac arrest. So yeah, like I said, potassium below 2.5 is when you really would see on an ABG or VBG. An ABG, and then on the monitor you would see ST segment depression. This is one of the common things that they always hit us on boards, and I'm sure for you guys too, on EKG questions. Low potassium. What do you see? The depressed T waves. You may see the U waves afterwards, like in the U shape, but that's not as common as the T waves. So hopefully that makes sense. It's hypokalemia. And then how do you fix it? It's just potassium. It's just not rocket. If you guys carry potassium, they're probably not. No, yeah, sorry, I'm just curious. I'm just like a lot of these things, unfortunately.
Yeah,
Yeah.
I don't really know what their levels are baseline.
Yeah. So that's why I was like, when I was doing this presentation, obviously, it's all medical knowledge. It's good for you guys to know all this, but it's like for practicality purposes, this is going to decide. It's like what can you guys do in the field? It's like a lot of these H's and T's. It's oh hey, it's nice to know what the cause is. I don't care about that. I care about how to fixing it, and then that's
This is one for sure.
yeah
The
yeah
other one, we do have some options. This is very little of anything.
yeah. So it's yeah, hypovolemia fluids, hypoxia, you can intubate them. This it's like you no one will remember this after this. So but like yeah, 2 mex per minute. So a lot of this is more hospital stuff, and you know, so hyperkalemia, the opposite, too much potassium. History of, you know, it's just when the cell, and a lot of these, the causes, it's shock, renal failure, sepsis, cell damage. It's a lot of just muscular energy. Cells are just traumatized. Their membranes, their walls break down. A lot of that potassium inside the cells just floods out into the tissues and into the vasculature, and so just the potassium spikes up. Also, a lot of the renal patients, if you know somebody, if you have someone who's in code blue and you know they have history of ESRD, end-stage renal disease, CKD, and they miss dialysis, Freeman, obviously, I mean, a short time, you see so many people come in with missed dialysis. Uh, you know, that's look for that. Think about that. Also, you can probably see on them if they have a fistula, either in the forearm or the ports up their upper chest. That can also be an indication of what may be the cause. But, on the monitor, when you hook them on the leads, you'll see in this case hyper, the peak T waves. You probably are aware of that, and also the QRS is widened. Uh, so just the prolonged depolarization. I'm not going to go into the physiology of the EKG, but that's kind of the lack of P waves are very depressed P waves as well. So, and again, you guys can't do much about it. There's a lot of options. Oh, you guys have bicarb.
We do have that. We kind of look at it.
Yeah. You do have calcium. Good. Yeah. So in this case, you do have calcium. You probably have bicarb. Insulin. Okay. Yeah. So in this case,
So we use the D10 now.
oh, there you go. Well,
We can fix hyper K a little better than hypo K.
yeah.
A few more options. Part of this is they try to know that they're a dialysis patient.
Yes. So like in this case, this is more of a maybe you could fix this. And again, key is getting to the hospital. But if you guys do have time, you know, hit them with albuterol. Hit them with a calcium gluc first of all. Can't hurt. Albuterol. What's that?
They're dead. That's part of the trouble. And this is ACOS. We're doing CPR, so some of these things are like,
Yeah.
who's gonna do that?
Yes, and yes, again, yes, and yes, and yeah. Thank you for reminding me again. I always have to remind myself. This is all in the setting of chest compressions.
They're not inhaling. We're forcing it.
And this is all in the setting of chest compressions and CPR and epi every 2 minutes and pulse checks every 2 minutes and all that chaos. So it's like, I mean, I'm not saying don't go into the details and minutia of what can we do to figure this out, but again, you know, if this is going to hamper transport or anything like that, you know, getting the meds drawn up and injecting them, then by all means, just get them to the hospital. That's realistic, while continuing chest compressions and pulse checks and epi and lido and all that stuff. So again, this is there if you need it, but like you said, everything is a very dynamic situation, and you guys know best. Oh damn, this is supposed to be at the end one. Hypothermia. This is I'm sure you guys have seen this in the field. You're not dead until you're warm and dead. I just found out you can't. So yeah, this isn't the crappy one. Cannot declare someone dead until their temperature is at least 89.6 degrees Fahrenheit, unless when you found them they were lack of oxygen. Well, unless you found them without oxygen and they were normal temperature and they had no pulse and then they decompensated. So you knew that they were lack of oxygen at a normal temperature, and then the temperature went down. At that point, you kind of knew what their status was when they were above 89.6. But if you find them below that, you can't officially declare them dead until they reach that temperature level, and that's through warming, cooling. And I actually remember stop me if I'm wrong at all any of this, but like I remember when I was a scribe back home in Chicago, where I'm from. Yeah, they had to. I was watching. They brought some girl in who they found in the cold in January in Chicago. No idea what happened. Just no witnesses or anything. She was just near a lake. They brought her in. Her temperature was like in the high 70s Fahrenheit. And they were doing chest compression. She was by all means dead, but they couldn't obviously declare until they got her temperature up to at least 10 more degrees, and they were doing chest compressions for 2 hours plus, just rotating it nonstop, and it was I've never seen anything like that. Have you guys ever had any situations where you just had to do? Wow.
Not that extreme, but yeah, we've had some cold people. They get cold here sometimes.
Yeah, yeah, and you're just nonstop, just doing it until you finally reach that threshold, right?
We know they're cold, and I know that
Yeah,
we don't have a great way of knowing their temperature. So
yeah,
if the environment matches, then they're probably cold. They're cold. We're going to do all the things until
yeah,
we get to you guys at the hospital and figure out a little bit more and
yeah,
confirm what we already knew.
yeah. I know. I remember that. I vividly remember that. That was January 2019. It was crazy how long they were doing that, and doctors just had a standstill. You could sorry, a lot of numbers here. So yeah, hypothermia. This is a lot of technicalities. Don't need to. I just went overboard with this. Sorry. Hypothermia is defined as mild, moderate, severe. Mild is anything 95 to 89.6, and this is kind of when they're conscious and alive. And you can see this in a lot of people in the hospital too as well. They're awake, they're just shivering a lot, letting off a lot of body heat, cold skin, tachycardia to compensate for all that. And then moderate hypothermia, this is where you get to that level of you cannot declare them dead. Anything less than 89.6 to 82.4 to 89.6, again, sorry for the technicalities. Just, just bear with me. And this is, they're still conscious, but they're extremely altered. Their body just doesn't have the energy to shiver anymore to make any sort of heat. Um, so, and then heart rate's down, everything's kind of shutting down. They're not breathing as well anymore. Severe, anything below 82.4. This is what I saw during my experience. I'm just mentioning, and again, this is, you can see, you'll still see them in VFib, but they're not conscious. They look dead in a way. Fixed and dilated pupils, but they still have a rhythm. Bradycardic likely. And you see the VFib. And again, you can below 75.2, there'll be asystole, but you still can't declare them dead. I mean, I've never seen anyone below that level. But again, you still can't declare them dead. Unfortunately, it's just for legality purposes, whatever you want to call it. Again, and this is where, and you can't do anything below, if the temperature is below 82.4. Oh, hey, what's up? So, a lot of words. Dang, we're at 11:30. Wow, talking a lot. Sorry. Mild to moderate. 15 more minutes to go.
You're doing great.
Oh, I'm good. You is cool. My interventions. I mean, it doesn't matter if they're mild and moderate. You guys I'm sure you guys have heating, warm. I mean, you guys have. Obviously, you guys have blankets and clothing. You guys have heating pads in the truck.
Nope.
Nope. Any warm water?
Yep.
Oh, you do. Sweet. Lamps and like those.
Nope.
None of that fancy stuff. Probably, yeah. I mean, whatever you guys it's kind of ad hoc. Whatever you could cover them up with, and kind of giving them just as much heat and retaining and closing the door even, and just closing windows and just having the the AC and the heat in the car, even in the truck, just ramped up. If you're doing it in the truck, you have heated fluids? Probably not.
Yeah.
We have warm.
Oh, you do. Cool. Warmed oxygen as well, right?
Nah.
Nah.
Not an easy way to warm it, so we can try, but not likely going to happen.
Yeah, I mean, you can even just get a lighter and just like, yeah, it's just kind of where you got to MacGyver it and just kind of whatever you get something that, yeah, even just get like if you have like just a lighter fluid, like some fire somewhere, and just like hanging the fluids next to it. I don't know. I'm just talking. So that's kind of that, and it's hypothermia is kind of the crappy one. It's just again, uh, just getting that temperature back up, and from there you can kind of assess if that's the cause or for something else. But maybe something underlying beneath the hypothermia. But until you get the temperature back up, it's hard to really tell what the cause is. So because we'd be masking a lot of things. Hydrogen ion acidosis. Gosh, why did I have to write so much? Acidosis negatively affects circulation as it causes peripheral. Wow, I plagiarized that. Impacts circulation as it causes Negative ionotropy, that's negative cardiac um, output, like contractility, blah. So just a lot of hydrogen ions in the low pH, a lot of hydrogen ions. You can see that through an ABG, VBG. And you'll see that people who have a history of renal failure, toxic ingestion, they're not breathing well, so CO2, a lot of retained CO2. They have DKA or alcoholic ketoacidosis. You'll see that elevated beta hydroxybutyrate. They're in shock, just not ventilating. Again, symptoms prior to cardiac arrest that you may, if you see them prior to them going into the code blue, they're just not respirating as well. They were drowsy, lethargic, just holding in a lot of CO2 and low respiratory rate. Kussmaul's respirations, that's just, you'll never see that. That's end stage. I don't think I've ever seen that a couple times, but don't look for that. That's always a fancy word on exams and boards, but it's not practical in the real setting. If you're at that point, then you're screwed anyway. Symptoms of acidosis. Oh, nice, a picture. Yeah, seizures, weakness, a lot of the muscular breakdown because there's a lot of hydrogen ions. Diarrhea, a lot of the bicarb, HCO3 gets pushed out, so that buffer is gone, so pH goes down. Nausea and vomiting as well. Respiratory shortness of breath, a lot of retaining a lot of CO2. Headache, sleepiness, confusion. You're obtunded. The respiratory center in your brain isn't telling you to breathe as much, so you're retaining more CO2. So that's kind of, it's all just, just a lot of CO2 retained. Acidosis, blood gas result. So yeah, there's two ways acidosis can be caused: the respiratory, which is a lot of retained CO2, and the metabolic, which is the bicarb is down. Respiratory ventilation. This is where the intubation comes in, or obviously increasing the number of bag mass compressions, the rate. Metabolic acidosis, bicarb. I've seen that injected in the field. You can give 50 of that 1 to 2 times. Although I've seen studies, bicarb, it's still the go-to to use, but in like medical jargon and research, it's not actually that effective. I've read in multiple areas, but it's still something to do, especially for you guys in the field. So yeah, I just still do it, obviously. And then obviously, if it's also, so it can be also associated with potassium. It's related to that acidosis and potassium, hydrogen, the buffer system. So treat also for the hypo or hyperkalemia. Moving forward, we're not at the T's yet. Okay, oh, sugars, sweet. This is not rocket science. I don't know why I did. What?
You said sugar.
Yeah. Oh, I knew that. No, shoot, I'm out. Damn, I was gonna bring candy. Shoot, I'm sorry. Blood sugar, yeah, and Halloween, just give them freaking whatever you want. IV, amp of D50. If no, just give them IM glucagon until you get IV access. You guys have glucagon on the truck? No, never ever.
Oh, we had it. Way expensive.
Yeah. Shove some candy down their throat. No, don't do that. Don't do that. So, what's that? Yeah. Anyway, back onto the T's. We're almost there. Tamponade. Has anyone ever done a pericardiocentesis? I don't know. Probably never. Amongst you three, and then no one else. Yeah. Are you guys trained ever do it? You guys even trained? You are.
Yeah, the procedure is high. It's just not something.
Yeah. Even in ER residency, I just started, but just talking to my seniors, they've hardly done it. It's something that they struggle to fulfill by the end of our training, and you just kind of just do it on dummies, just to get that check mark. But yeah, it's very rare. The video. Is there a way to play that video?
It might play the video.
I don't know. I forget what the video was for. So let me just go through this. Essentially, it's fluid around the heart. Heart's obviously in a sac.
Is it a link?
Yeah.
At the bottom of your slide there, you can use the mouse there.
Control. I can get out of the. Oh. Yeah. So it is. Can I go to the internet? I forget what this video is, to be quite honest. Oh. Cross fingers. Oh, it's ultrasound. Yeah. Oh yeah. I don't know if anyone can hear this. Sorry. This is more of an ultrasound. I guess not sure if you guys even have ultrasound in the truck.
You walk over here,
Oh.
you got a microphone on your shirt.
Yeah, this video is just a.
Right there.
Oh, okay.
Is it gonna play?
Above your head.
It's actually right there. This
Oh, hey.
You don't have to hold it up.
You don't. I'll just turn it.
Yeah. So this is just a video of a pericardiocentesis. Obviously, it's in the hospital field, and I'm sure I don't think you don't have portable
Start
ultrasounds.
by viewing the heart using the subxiphoid or the parasternal view. Fluid within the heart should appear black. The presence of fluid outside the heart within the pericardial sac is abnormal and is consistent with pericardial tamponade.
Sorry, that's what that is. And yeah, this is where I don't know. Now you ultrasound should be in for all you guys. I mean, it's what they say. It's the new stethoscope going forward. I mean, I'm still learning it, and it's just such a helpful tool. Oh, thank you, sir. Oh, thank you. Yeah, I'm like this actually holding it. So that was just a quick video on the ultrasound. I mean, hopefully in the future you guys will give you portable ultrasounds because it's. I mean, again, it's hard to do during chest compressions and during CPR, but when you're doing a pulse check, you can quickly just throw that on there and subxiphoid and check. And again, but this is also one of those things where you know what's happening, but what can you do about it? Not much, especially you see so little of these. I mean, if you're trained, obviously you're trained for it, and if you can, the next video will kind of give a quick idea of a pericardiocentesis. But what do you see? The narrow QRS, elevated heart rate, distended neck veins, muffled heart sounds, hypotension. But then those triad, that Beck's triad is what they call it. You may not always see that, so it's not always specific for tamponade. And what kind of people do you see? Tamponade, obviously traumas where they had some sort of blunt trauma to the chest and the fluids just building up around the heart, or I'm not penetrating, excuse me, but also blunt. If they have some sort of cancer near the chest, and lung cancer, or even some sort of mass in the valves of the heart. But again, you guys don't know that. It's also the presentation is also actually very similar to tension pneumothorax, especially if there's a tension pneumo on the left side. But obviously with tension pneumos, you have lack of breath sounds on the side where it's at, and if it's on the left side, you won't hear any breath sounds on the left. But if it's tamponade, you'll still hear breath sounds at both sides. So it's kind of the one quick way to distinguish between both of those. That picture kind of sums that up. I'm gonna try this once again. Sorry. Oh shit. What kind of presentation do you do? 1 second. Uh,
5 to 10 acceptable for me.
Let me find the proper time frame for the lady who's doing it. It was around 7 minutes. Because I don't want to do it. Should I tell you how to do it? There we go. Oh.
Both are most easily accomplished with the second provider manipulating the syringe while the first provider stabilizes the needle. Positioning and landmarks. During active cardiopulmonary resuscitation, the patient will be in supine position. The xiphoid process should be palpated in a subxiphoid approach, which is between the xiphoid process and the left inferior costal margin, will be the most optimal approach to use when a patient is actively receiving CPR. Procedure. Start by cleansing the skin. During active cardiopulmonary resuscitation, the patient will not require local anesthesia, but this should be considered for elective or semi-urgent procedures. Connect the syringe to the needle gently so that it may be easily removed without disrupting needle position. Cardiopulmonary resuscitation should be briefly paused during the advancement of needle and aspiration of syringe. Insert the spinal needle in the subxiphoid region between the xiphoid process and the left inferior costal margin. Angle the needle underneath the rib cage no more than 45 degrees to the patient's skin and aim the needle towards the patient's left shoulder as you continuously aspirate the syringe. Short, quick jabs, as opposed to slowly advancing the needle, are required in order to penetrate the parietal pericardium and to not tent it against the visceral pericardium. Advance and aspirate the needle until fluid, blood, and/or air is obtained. The distance from the skin to the pericardium is based on body habitus. If no fluid is obtained, withdraw the needle to just underneath the skin and angle the needle more posteriorly, closer to a 45-degree angle, and re-advance the needle while continuously aspirating. Remove and flush the needle after several failed passes. If ultrasound is available, confirm the needle is in the pericardial space and not in the heart with an apical 4-chamber view. Secure the needle at the skin with your other hand to make sure the needle does not move unnecessarily during the procedure. Change to a larger syringe and continue removing fluid. Remove the needle when you can no longer aspirate fluid, and remember to resume cardiopulmonary resuscitation.
Yeah, that was just quick. I'm not going to go into the other rest of the video. I mean, oh, I had some notes somewhere. Is there a presentation view? Oh, presenter view. Is this the presenter view or? They got some notes.
Oh, you have notes?
Yeah, it's okay. We're almost done. It's fine. Don't worry. Make it regular. We're almost done. You guys,
Remember when they're at?
I do, but
what are you looking for?
he was looking for it.
No, it's okay. It was more because I was nervous. I was like, oh, but you guys are super chill and nice. So we're almost done. You can proceed. So that was a quick video on pericardiocentesis. I mean, it looks simple and it's actually not that bad. I mean, I've never done it, so what can I say? But I mean, you guys are very skilled with your needles and stuff. So I mean, if you have the gonads to do it, I mean, and you know and you're pretty confident, it's go ahead. I don't know. But that's what that is. Tension pneumos, I'm sure you guys have seen a lot of these and probably fixed a lot of these. Trauma history, any sort of blunt trauma, rib fractures, asthma, COPD, and then just blown, the lung is just blown out. This is where you see the unequal breath sounds, lack of breath sounds on one side of the chest. Distended neck veins, deviated trachea, hard to ventilate, a lot of air when you listen to them on the side of the tension pneumo. I mean, I'm sure this is something you guys have probably seen a lot. And ECG, you don't diagnose it through the ECG, but you see the narrow QRS and bradycardia. Interventions. Oh man, screw the video. You guys have probably done this decompressions in the field. A lot of you guys. So I'm not gonna. You guys know better than I do. I'm not gonna screw that video. It's essentially just shoving a needle in at the inner space of the ribs, hearing that whooshing, and then which intercostal space do you recommend, third to fifth?
Yeah, third to fifth minute actually.
Yeah, sorry, thank you.
The anterior plane.
Yes. So I mean, these are. I've never seen this, but I'm sure it's probably. I'm sure it's a very satisfying feeling. I've seen chest tubes. That's what you do. Obviously, first do the needle decompression, and then the chest tube if you can later. But yeah, I'm sure it's a very satisfying feeling when you get those in. Also, if you don't have a needle, if you just stick your finger in there, there's also people. It depends on body habitus and also the catheter. That's that. PEs. These are also this thrombosis ones. Sorry. The ACS. These are hard to figure out in terms of fixing during code blue. I mean, their history of patient prior, if you know anything about them, those are actually very good breadcrumbs to kind of telling you that they probably thrown a clot, cancer, history of clots, surgery. All of a sudden they're just ventilating a lot, and hyperventilating, tachycardic, chest pain, some skin changes. They may be throwing a PE. On an ultrasound, you would see strain of the right side of the heart. The right ventricle is deformed. It's as equal, if not larger, than the left ventricle, when normally it shouldn't be. I think I had a video somewhere, but I'm not going to bother with that at this point because I'm actually sweet. No, I'm good. I'm riding on extra time now, so. So you'll see on clinical exam neck vein distension, maybe unilateral calf swelling or thickness, a DVT, a narrow QRS complex. You'll see a PEA, 36 53% of cardiac arrest is caused by PE, so it's actually a pretty common cause. This is actually a nice chart. I found somebody doing this. You'll see a PEA rhythm, unilateral swelling, and clinical findings, and then a known history of PE is a hypocoagulable state. On the ultrasound, if you have one, a DVT, right thrombosis in the right heart, right ventricle dilation. And so you guys don't carry thrombolytics probably in the trucks, so this is irrelevant to you. And actually, I've also read multiple times that thrombolytic therapy in the event of a cardiac arrest is actually not very effective in the field. So it's actually, they give you guidelines to do it based on what you see right there, either tenectoplase or alteplase, and you can see right there how long to do it, when to give it. But it's actually scientific, like just from a therapeutic, like numbers wise, it's not that, it won't affect the outcome all that much, but it's just something to do if you were just at a standstill. Oh, hey, there is. So actually, yeah, there's the video did work. So that's the thing on the right. That's the left ventricle. The right ventricle is also dilated. So you see like the thickness of the left ventricle in the middle, and then the right side of the right ventricle, which is dilated. So that's kind of what you would see if you had an ultrasound. So that's what PEs are. Again, that's something that's more of a hospital thing that you can fix. For you guys in the field, just focus on chest compressions and Lido, Epi, all that stuff until you get them. So not much you can do about that to fix in terms of reversibility. And also for heart attacks, not much for you guys that you guys can fix in terms of in the field. This is where you just need a cardiologist to come do a cath. That's the only way. As long as you can get them back to ROSC, and then the only ultimate outcome for ACS is cath, PCI. And then how do you know that it's been a heart attack? The cause in the code blue, cardiac history, CVA, diabetes, all those stuff that you guys that are indicative for heart disease. Symptoms that you guys see for heart attacks: chest pressure, chest pain, dull ache, the heaviness of squeezing, not the stabbing. Stabbing is more probably acid reflux, but the dull ache that happen at rest, and the diaphoresis, the palpitations, nausea, the vomiting, all that stuff that's common associated with heart attack. They said in the ACLS book, troponins. You guys aren't doing troponins, obviously, in the field. Frick, it takes us 2 hours to get troponins in the hospital. So, but definitely on the EKG, ST segmentation is the elevation for an acute MI, the depression that maybe show like a suspect oncoming or old infarction, the T wave inversion, the deep Q waves that are much deeper than the standard Q waves. You see that, and this is all I had for ACS. I mean, you guys can't do anything. Just get them a cardiologist, get them to the hospital. So just focus on your basic chest compressions again.
So for the component levels, it's important for us to know those whenever we're transferring.
Oh, okay, yeah.
So we do get those. Sometimes we just don't draw them ourselves.
Mm-hmm.
So when we bring them from like Firmino shows, they do tell us
the
troponin levels with their.
Oh, okay.
So they do tell us.
Oh, okay. This is when if they become unstable, or they're stable, then they be.
So like if it's they're at Firmino show,
Yeah.
Firmino show you can transfer.
Yes, correct.
So,
Okay. Yeah.
so we do get those. We just don't draw them ourselves.
Fair enough. I mean, yeah. Okay. Thank you. Toxins is the last one. I mean, and this is where you can see why this is my last slide that I probably did this morning. There's a bunch of things. It can be God knows what. The ACLS book specifically pointed out beta blockers, calcium channel blockers, digoxin, and TCAs. As you can see for like even beta blockers, calcium channel blockers, the presentation on ECG is pretty similar, even for digoxin. So it's hard to kind of determine at that point, but that's where medical history from family members at bedside when you arrive, what have they been taking, looking at their pill bottles, if they have any, look in a bag. What does it do to? But like in terms of reversibility, again, this is where you have to kind of manage symptomatically. And poison control can have the most direct outcome, direct guidance on how to kind of manage it. But in terms of like in the field, again, for you guys, it's not much you can really, unless I'm mistaken, but it's not much that I noticed or read that you guys can really address in the field. TCAs actually did on a truck see someone take 11 of amitriptyline overnight. Some stupid guy. Sorry, he was stupid. But he was actually not symptomatic. He didn't show. He was conscious. He was diaphoretic and kind of flushed, but otherwise he was conscious. He was awake and breathing well. But you still see that a lot of people just overdose on TCAs. Really, cocaine also. Which you guys see a lot, cocaine overdoses. But again, that's just more. There's no singular antidote for that. You just got to kind of manage the chest pain, the cardiac symptoms that come with that. Cocaine overdose, opioids, Narcan is the end all be all for that. And heroin overdoses, anything like that. Well, interventions wise, I should have said that or said earlier. You can't really do much for you guys in the field, but yeah, like you do for the calcium channel blockers, you can give calcium gluconate and insulin with the glucose to kind of address that. So I correct myself. But you guys don't obviously have glucagon anymore, so you can't do much for the beta blocker. Digoxin, don't worry about that. Bicarb, you can't give for the TCA overdoses, you can give bicarb. ECMO, that's extracorporeal membranous oxygenation. Not much you guys can do with that. I think that's it. Sweet. Thank you, everybody.
I asked about questions a bit ago. I have not seen any,
Yeah, I'm not answering any questions.
they're looking. They're a little bit behind.
I will see somebody this week because I have to do a shift one more with you guys, so I'll be back this weekend.
Presentation.
You guys are done. Enjoy your Fridays.
Yeah.
Thank you so much, everybody.
Anything else?
No.
Saw a great presentation.
Great presentation. Thank you. Thank you.
That's a lie. It's a lie, but I'll take it.
Yeah. We got to start somewhere. It's probably your first time presenting big time, kind of with a little bit.